Hi, this is Jacob Avila of 5 Minute Sono, and this is how you use ultrasound in the evaluation of shock. When you're doing this exam, you're basically doing what's called the rush exam, and that's rapid ultrasound in shock and hypotension. There are two schools of thought regarding how to approach the patient with undifferentiated hypotension by using the rush exam. One is the pump tank pipes method, and the other way is the HIMAP method. I'm going to focus on the HIMAP method. What that stands for is heart, IVC, Morrison's pouch, which is a fast exam, the aorta, and a pulmonary exam. Let's start by talking about how to do the heart portion of this exam. There are three things that you need to evaluate when looking at the heart, and those are global function, right heart strain, and the presence of a pericardial effusion or tamponade. Let's talk about global function first. There are four different ways that you can estimate global function, and that's visual estimation, method of DIST, fractional shortening, and EPSS. We're going to focus on visual estimation and EPSS. The visual estimation method is often a lot easier when you've done a few echoes and you know what normal and abnormal looks like. If you're just starting out, the EPSS is a good place to start. When you're placing the probe on the patient, it's going to go in the left sternal border, probably around rib spaces 2 to 4, with the probe marker facing the patient's left hip. And these are the images that you should get. On the left side of the screen, you see a parasternal long axis view of a heart that's beating well. You can see here the ventricular walls are coming together nicely. The mitral valve is coming up and nearly hitting the septum here. Now compare that to this image over here. You have the same parasternal long axis view. These ventricular walls are not moving very well, and this mitral valve is not moving very well either. This is a patient with a low ejection fraction. This is a patient with a high ejection fraction. Now, if that's something that is a little bit difficult to see, you can always do an EPSS estimation. So when you're doing an EPSS, you want to put the M mode cursor just right over the end of the mitral valve leaflets, right about here. And this is the tracing that you'll get. If we zoom in, we'll notice that we have the septum up here. We have our E wave and our A wave. What we're looking for is we're looking for the distance between the septum and the E point right here, and that is called the E point septal separation. If you have an EPSS that's greater than 10 millimeters, it's highly specific for heart failure. If you have an EPSS that's less than 7 millimeters, it's pretty sensitive for ruling out heart failure. Next, let's talk about right heart strain. The best view for this is going to be the apical 4-chamber view. You're going to stick the probe in the point of maximal impulse. I usually start right underneath the nipple and I move around until I get the image that I want. And this is the image that you should see with the ultrasound. You have your left ventricle on this side of the screen, the right ventricle on this side of the screen. And what you want to evaluate is the ratio between the left ventricle and the right ventricle. The right ventricle should be about 1/3 the diameter of the heart, and the left ventricle should be about 2/3. Really, the ratio that we care about is 1:1. If the right ventricle and left ventricle ratio is greater than 1, then that's something that's abnormal and we need to evaluate further. Here's a clip of a normal apical 4-chamber view. We have our left side of the heart over here and our right side of the heart over here. Notice that the left side of the heart is much bigger than the right side of the heart, which is what we want to see in this image. Now compare that with this one. A lot different, right? Here's the left side of the heart and here's the right side of the heart. The right side of the heart is definitely bigger than the left side of the heart. If you have a patient that's acutely short of breath with an enlarged right heart, be highly suspicious for a PE as the cause of a patient's dyspnea. Here's another echo of a patient with right heart enlargement. If we focus in here on the apex, we notice that the right ventricular apex is hyperkinetic relative to the free wall of the right ventricle. This is called the McConnell sign. Previously, the McConnell sign was thought to be highly specific for a PE, but subsequent research has shown that that's just not true. The McConnell sign is actually very specific for acute right heart strain, which can happen in a PE and it can also happen in a right ventricular infarction. The last thing you have to evaluate when looking at the heart in a patient with undifferentiated hypotension is the presence of a pericardial effusion. You're going to place a probe in the subxiphoid area with the probe marker facing towards the patient's right this way. And this is the image that you should see. You have a little bit of the liver up here, the right side of the heart here, and the left side of the heart down here. Here's a patient with a small pericardial effusion. Here's the liver up here, right side of the heart, left side of the heart, and here this little sliver of anechoic or hypoechoic fluid right there is a pericardial effusion. This patient does not have tamponade because the right ventricle is contracting exactly the way that it should. This patient does not have hemodynamic compromise, so they don't have tamponade. Contrast that with this image right here. You have a very large clot in the pericardium and the right ventricle is completely collapsed, unable to fill. This patient definitely has obstruction and has signs of tamponade. The next portion of the rush exam is looking at the IVC. The IVC is a pretty decent marker of what the CVP is. If you have an IVC that is plump, dilated, not moving with respiration, be suspicious of high CVP in a patient. If the opposite is true, you have an IVC that's flat, completely collapsing when the patient breathes, be suspicious of the patient having a low CVP. As far as where to put the probe on the patient, you already had it in the right area. You just got to orient your probe marker differently. So go ahead and rotate it clockwise so that the probe marker is facing up, and this is the image that you'll see. On the left side of the screen, you have a patient with a very small IVC. It's a little sliver of an IVC. It's completely collapsing. This patient has a low CVP. And on the right side of the screen, you have a very plump IVC. It's not moving very much with respiration. This patient has a high CVP. If you have a patient with low CVP, be suspicious for a hypovolemic distributive or neurogenic shock. If you have a patient with high CVP, think about obstructive or cardiogenic shock. The next part of this exam is Morison's pouch, which is really just the FAST exam. The reason Morison's pouch works is because Morison's pouch, which is the right upper quadrant view, is the one most likely to be positive if you're going to see blood in the abdomen. The FAST exam stands for Focus Assessment with Sonography and Trauma, and you're going to look for blood in the abdomen or pericardium. We've already talked about how to look for fluid around the pericardium, so I'm going to focus on the abdomen. When you're placing the probe on the patient, you want to put it in the mid-axillary line with the probe marker facing up, and you want to see an image like this. You have your liver up top here with your kidney down here. It's very important to evaluate the inferior pole of the kidney and the caudal tip of the liver, this little triangular area right here, because this is where fluid is usually going to accumulate first. Eventually it'll go in between and get in between the kidney and the liver, but don't forget this inferior pole down here. This clip represents probably the most important part of the right upper quadrant view, and that is evaluation of the caudal tip of the liver and the inferior pole of the kidney right here. Fluid's going to accumulate first in this little triangular area right here, and then kind of seep along here and get in between the kidney and the liver down here. So make sure you look at this area first and then look down here. The right upper quadrant is a 3D area, so you want to still make sure to fan all the way through, up and down, because fluid is not necessarily going to accumulate where it should because, patients don't follow textbooks. Here's a clip of a positive right upper quadrant FAST. I like this clip because it emphasizes the point that you have to look down here between the caudal tip of the liver and the inferior pole of the kidney. If you only looked here, you might actually miss that this patient does have significant intraperitoneal fluid. The next most common place for fluid to accumulate is going to be in the pelvis. You want to use the curvilinear or phased array probe. You want to stick it right above the pubic symphysis with a probe marker facing up towards the patient's head. In a male patient, this is the image that you're going to see. Fluid's going to accumulate behind the bladder. Here's an image of a positive FAST in a male. We have our bladder, and then we have our free fluid in the perineum right here. This is a positive FAST in the pelvis. In a female, it's going to accumulate in a slightly different area. If you have a normal aneverted uterus, the blood's going to accumulate behind the uterus. If you have a retroflex uterus, the blood might accumulate between the bladder and the uterus. And here's a positive FAST in a female. We have our bladder up here, our intestines moving around right here, a little bit of free fluid here, and a lot of free fluid down here behind the uterus. The last part of the FAST exam involves looking at the left upper quadrant. The left upper quadrant is not a mirror image of the right upper quadrant. There's the spleen inside of the liver, and there's a lot of other kind of changes in architecture. Basically, you have to look at a different area than you do with the right upper quadrant. When you're placing the probe on the patient, you want to put it in the posterior axillary line because the spleen's smaller. And this is the image that you want to look at. Ignore this giant stomach up here. Focusing on the spleen here. Instead of fluid accumulating down here or even in between the spleen and the kidney, it's most likely going to accumulate suprasplenic or subdiaphragmatic up here above and anterior to the spleen. And then when it gets bad enough, it'll get in between the kidney and the spleen. Here's an ultrasound image of a positive FAST on the left upper quadrant. We have our kidney down here, our spleen's here, we have some free fluid, and down here we have a bit of a clot. This image is one of my favorite ultrasound images because it proves an important point. Were this the right upper quadrant, let's say this is the liver, let's say this is the right kidney, I'd actually be okay calling this a negative FAST because in this kind of triangular area between the caudal tip of the, we'll say, liver and the inferior pole of the kidney, I don't see any free fluid down there. But this is the left upper quadrant and you have to look in a different area. Instead of looking between the caudal tip of the liver and the inferior pole of the kidney, we have to look above the spleen or suprasplenic. And in this image, we will see a grossly positive FAST with free fluid up here above and anterior to the spleen. The next part of the Rush exam involves looking at the aorta. Before I go on and talk about it, there are three things that I need to mention. First off, a diameter of the aorta greater than 3 centimeters is considered abnormal. If you have a diameter greater than 5 centimeters with hypotension, that is a ruptured AAA until proven otherwise. And lastly, you have to make sure to measure the outer wall to the outer wall, not the inner lumen, the outer wall to the outer wall. Very important. When you're putting the probe on the patient, look as proximal as you can to try and find the aorta, and go ahead and move down until you get to the bifurcation of the iliacs. Here's an ultrasound image of what you should be looking for. On the right side of the screen, which is the left side of the patient, you have your aorta, your IVC's on the right side of the patient or left side of the screen, and then right here you have the vertebral body. These are going to be your landmarks. And this is what it looks like when you actually are scanning the patient. So you follow the aorta all the way down until it splits into the iliacs. Here's an image of a big AAA. You can see this big old structure right here. It's almost the same size as the vertebral bodies. Definitely abnormal. Here's another image of a AAA, and I like this one here because I can show you why it's so important to measure the outer wall to outer wall. If we only measure the inner lumen, we would say, hey, it's 2 centimeters, it's normal. But we have to measure the outer wall to outer wall, and we find that this is a 7 centimeter AAA, very large in size. If you're not sure which one's which, you can always throw some color flow on there to help you figure out where the lumen is and where the outer walls are. And here's an image of a really big AAA. You can see it from here to here, probably about 12 centimeters. You can see it going all the way into the iliacs. This patient needed to go to the OR right away. The last part of the rush exam is the pulmonary component. There are 2 things you need to evaluate, and those are pneumothorax and a pulmonary effusion. We're going to focus on pneumothorax first. You should use a linear probe, and when you place it on the patient, you want to put it in the most anterior part of the chest wall. If the patient's laying down flat, you want to look at rib spaces about 4 to 5. If they're sitting semi-upright, you can go up a little bit higher around rib spaces 2 and 3. This is the image that you should be seeing. We have our ribs right here in cross-section. We have our rib shadows underneath it. We have our intercostal muscle in between, our skin, subcutaneous tissue, and muscle above, and this line right here. This is the pleural line, or the VPPI, stands for visceral parietal pleural interface. This white line is always going to be there, but what you're looking at is you're trying to see if there is relative motion between the 2 pleura in the form of lung sliding. Contrast that previous image with this one right here. That white line is still there, but it's not sliding back and forth. Yeah, it might be moving up and down a little bit because those intercostal muscles are pinching, but you do not see this side-to-side movement that you need to see in order to be able to say the patient has lung sliding. If you see the absence of lung sliding in a patient in the right clinical setting, be suspicious for a pneumothorax. The last part of the rush exam involves the evaluation of a patient for a pleural effusion. You can do this at the end, or you can do it with the FAST exam. The reason I say that is because the location is very similar to the FAST exam. You're just going to be looking at a slightly different area. If you can get the patient to sit upright, you're actually going to be a little more accurate. This is the image that you're going to be looking at right here. It's very similar to the FAST exam like I mentioned before. So this is the right side. If it's a FAST exam, we want to look down here. If it's the left side, we want to look up here. But what we really care about is looking at the diaphragm, which is this white line right here, and we want to compare what's above and below the diaphragm. So using this still image, I'm going to talk to you about 2 ways that you can evaluate for the presence of a pleural effusion. The first one is called the Mears sign. If you look below the diaphragm and above the diaphragm, you notice that the texture is very similar. In fact, it's identical. The reason for this is the following. When you have an air-filled structure right next to a fluid-filled structure, it creates such a reflective surface that it actually causes there to form a sonographic mirror. So if what you're looking at above and below the diaphragm are similar, that's called a positive Mears sign, and that means usually that there's no pleural effusion there. The second sign that I want you to look for, which is the one that actually I use more, is something called the spine sign. If you look to see where these arrows are pointing, you see that there's little kind of humps that you see. These humps, as soon as the diaphragm shoots off, they disappear. These little humps represent the vertebral bodies, and obviously in the thorax the patient still has vertebral bodies. However, with an air-filled lung, the sound can't reach the thoracic vertebral bodies, so if the ultrasound machine can't see it, it doesn't know that it exists. Contrast that with this image right here. First, let's look at the Mears sign. If we look below and above the diaphragm, we see that the textures are different. This anechoic fluid collection right here represents a pleural effusion right next to a liver. Next, I want you to look at the spine sign right here. We see a spine here, spine here, spine here, and we see it extend all the way past. The reason that we can see it above the diaphragm is because there is something that's able to transmit sound to the thoracic vertebral body so we can see them. In this case, it's a pleural effusion. Sometimes patients can have both intrathoracic and intra-abdominal fluid. Here, we see fluid in the abdomen plus fluid in the thorax. You can actually also tell the difference between a transudative and exudative effusion. Here we can see hyperechoic little flecks of particulate matter here. This some people have called the plankton sign. And if you see this, be suspicious for an exudative effusion. To recap, when you're doing a rush exam, think of the mnemonic HIMAP. And what that stands for is heart, IVC, Morrison's pouch, which is the FAST exam, the aorta, and a pulmonary exam. For the heart exam, you're going to look for a pericardial effusion or tamponade, right heart strain, global function. For the IVC, you want to know if it's plump or if it's collapsed. Morrison's pouch, you want to look for a FAST exam, so it's right upper quadrant, pelvis, and left upper quadrant. The aorta, you want to know if it's dilated or not. Greater than 3 centimeters is abnormal. Greater than 5 centimeters with hypotension is a ruptured AAA until proven otherwise. And make sure you measure the outer wall to the outer wall. The pulmonary component involves looking for a pneumothorax and a pleural effusion. And that's the end. Please feel free to email me or send me a tweet if you have any questions. Thanks.